Okay, great. So let's go ahead and get started. I am Dr. Lapage, and tonight we're going to talk about cardiovascular pharmacology. So let's take a look at our outcomes. Upon completion of this presentation, the participant will be able to apply the nursing process to the administration of those particularly cardiovascular meds, apply the actions, side effects, and nursing interventions to administering those cardiovascular medications. And then we're going to apply and look at and evaluate the serum lab results that are required when we're administering some of these cardiovascular meds. So, the ones we're going to talk about tonight in particular are going to be your ACE inhibitors, your beta blockers, calcium channel blockers, some of your diuretics, and then antiarrhythmics and cardiac glycosides, which are also function and serve as some antiarrhythmic medication. So, antihypertensives, when they administer or prescribe these medications, they could be a single medication or they could be a combo medication. Most often, a lot of patients will receive these medications in combination. They typically will start with possibly your hydrochlorothiazide, which is also, it's actually classified as a diuretic. Sometimes patients need combination medications with your losartan and the hydrochlorothiazide to decrease the swelling or the fluid retention that may occur with hypertension. So each class is going to work on a different part of the body. Some work by reducing the amount of water and salt in the body. Those are going to be your diuretics. Some work by relaxing the blood vessels and keeping them from narrowing. That could be also your statin medications because they're going to keep the plaque from forming and the cholesterol, disrupting nerve activity that restricts blood vessels, or they could decrease the heart rate and the force of heart contractility, or increase the force of the heart contractility. And those are going to be your ACE inhibitors and some of your rate control medications. Sometimes your beta blockers, because those are also used as rate control and heart rate control. So the first ones we're going to talk about are your ACE inhibitors, and those all end in prils. So when you see in one of the next slides, you're going to notice that when you look at the ones that fall under these classifications, they all end in pril. So I tell students to learn the medications by classifications and then kind of remember what medications or memorize what medications fall under those classifications. Because medications are classified according to how they work on the body, could be on what particular part of the body, or it could be their chemical makeup, but they're all under those classifications, are all basically going to work the same. So your angiotensin converting enzymes, these medications are going to reduce the amount of angiotensin in the body, and then by doing that, it helps the blood vessels to relax. It's going to that also by converting that angiotensin 1 to angiotensin 2, it's going to cause vasodilation, excretion of sodium water, and then potassium retention in the kidneys. So that's going to help preserve those kidneys, preserve the kidney function. And why do we want to preserve the kidney function in patients who have hypertension? Because hypertension can also lead to, and chronic prolonged hypertension can lead to kidney failure and renal failure. So remember, hypertension and renal failure kind of go hand in hand, and the kidneys and the renal system also help control your blood pressure because of those angiotensin 1 and angiotensin 2. Remember way back from from pathophysiology, how the angiotensin converts and what all the enzymes do. So, kind of keeping that in mind, they're going to work on the kidneys as well to preserve that kidney function, which is why they typically start with your prills. So, we use them for hypertension, heart failure. Typically, a lot of times patients will be put on these post myocardial infarction, MI, heart attack. They can also be used for neuropathy if it's either diabetic or non diabetic, because these patients tend to have decreased mobility then. So you can see the examples are all going to be enalapril, benazepril, lisinopril, rampapril, moexapril, fosinapril, and then this one is the only one that does not end in pril, but it's enalapril. Um, the antihypertensives are also used post MI because it helps decrease the mortality rate in these patients, and it's going to preserve that left ventricular function. I kind of think of the heart, we have the atrium and then we have the ventricles. The ventricles are bigger, so we want to preserve, and that's what pumps the blood out. We want to preserve those ventricles. And anytime somebody has a lethal rhythm, it stems from those ventricles. So if that's not pumping or not functioning, especially your left ventricle, because we remember from anatomy that that is the larger ventricle, that's the one that forces the blood out to the body. So if it's not forcing the blood out to the body, these patients can wind up with hypertension plus heart failure and all the things that go along with it. So they're placed on these medications. What are some of the side effects of these medications? Well, the biggest one, and lisinopril is the biggest culprit of it, for your African American and your darker skin population, it's angioedema. Has anybody ever seen a patient with angioedema?
No.
No? Okay, it can be kind of scary. Angioedema is swelling of the face, mouth, tongue, lips. Meanwhile, you can zoom on your side. It has helped on my side. Yes, you can increase the size on your side. On my side, it for as far as the slides, somebody was asking if we can increase the font. Um, if I increase it on my side, it's going to be too big, and then I won't be able to see it. You do need to avoid some of these medications in
Can we see
pregnant.
the slide, Professor? Sorry to disrupt, but can we see the slide?
Yes, I'm going to go back to the slides, but I'm reading the chat right this minute. I'm going to get to the slides. So, angioedema is that swelling. It can be life threatening. What do you want to be aware of, or what do you want to assess in a patient who has lip, mouth, or tongue swelling? What do we want to prevent from happening?
Airway obstruction.
Airway obstruction, absolutely, yes. So we tend to see angioedema. Now, remember, when a patient has an adverse reaction to a medication, most often it can occur on the first or second dose of that medication. With lisinopril and that angioedema, these patients can be on this medication for years, and then they develop the angioedema, and they can be fine on it and have one episode. I had a gentleman. I've seen multiple cases of angioedema working in the emergency room, but the one that stands out to me the most, I had a gentleman come in, woke up with right sided upper and lower lip swelling, and it was just right sided. It was increasingly getting worse, so he came into the emergency room about 11 in the morning. We treat that angioedema with racemic epinephrine, which is aerosoled or nebulized epinephrine. We gave him an epinephrine injection, the IM injection, and we gave him, we call it the cocktail, for treating allergic reactions or adverse reactions. So we got solumedrol, which is a corticosteroid that's going to help decrease the swelling. He got an H2 blocker because remember, anytime there's any foreign body or anything that starts occurring with the body, our histamines are going to react to increase swelling. And somebody who already has swelling, especially around the airway, we don't want that swelling to increase anymore. So we give them an H2 blocker, specifically Pepcid, because that works on the GI system. And it's famotidine, Pepcid. And we also give diphenhydramine, which is your antihistamine. That's going to help decrease that reaction. So one of the things we definitely have to watch for is what we call a rebound effect. So remember from basic pharmacology, your half-life for your medications. Well, the racemic epinephrine is going to wear off in about 3 to 4 hours. This was the only time I'd ever seen anybody have what we call a rebound reaction. So once that epinephrine wore off, this patient wound up swelling all over again. And his swelling now encompassed both sides of his mouth. He was getting better. He was able to take some ice chips on the right side when the original swelling and over the 4 hours. And he was actually going to be admitted because the swelling hadn't gone down completely. And it was about the 4-hour mark. Well, this patient had to be rushed to the operating room to wind up getting a temporary tracheostomy because we couldn't even get an ET tube in this patient because there was so much swelling and it had extended from just the lips down through his tongue and his throat. So we can see very, very severe reactions. And this patient had been on lisinopril for probably, if I remember correctly, it was about 2 to 3 years. So I've also seen other patients who have come in with being on it for years and have angioedema. So it can be pretty life-threatening, but it is, if I was a person that high susceptibility of having angioedema from it, I would not let them prescribe it for me because, but sometimes we never know. In your Caucasian patients, they typically get that dry, hacky cough, which can also pose an airway problem if they continue to cough, if it puts them into bronchospasms. So we really need to monitor these patients when they're on these medications. Other side effects are hyperkalemia, and we know that hyperkalemia can cause cardiac arrhythmias. So they need to be monitored. Their potassium needs to be monitored. Can cause a rash. Dysgeusia is your altered taste. So patients do complain of that. Captopril is one that in particular can cause neutropenia, and then it can cause hypotension. So if we're using it to treat hypertension, we don't want that hypotension. We want it to normalize that blood pressure. Does anybody have any questions on this so far? Affect African American the most? Yes, it does. We do want to avoid it in pregnancy, and yes, the dry cough. Good. So our contraindications, there are patients who have angioedema as a disease process, and they typically develop angioedema in the abdomen. So if they've had any form of angioedema or any history of it in the past, they're not going to get these type of medications. It is category D for pregnancy, so they're not supposed to be taking it. And then any collagen vascular disease is going to increase their risk for neutropenia. even though these medications, remember we said it preserves the potassium or spares the potassium in the kidneys, we still need to be monitoring that potassium level so that we're not getting any cardiac arrhythmias associated with it. So, one of the things I wanted to point out with dysquesia, the altered taste, what happens when somebody has altered taste? What do they reach for? What are they going to put on their food to make it taste better?
Salt.
Salt. And isn't salt contraindicated in hypertension, right? So we really need to do a lot of education. Maybe get some of that Mrs. Dash that's salt free or low sodium. Or instead of maybe using garlic salt, use garlic powder. Or instead of onion salt, use onion powder. So a lot of education goes along with these medications as well. Some interactions with some of them are your diuretics because of that risk for hypotension. Potassium supplements are going to increase that potassium level. So we really need to talk to the patients about not taking over-the-counter supplements, especially if they contain potassium along with it. And then check in their multivitamins, make sure there's not too much potassium in them. And then your potassium-sparing diuretics, because remember, those are they're gonna spare potassium. They're going to keep the potassium in the kidneys and not excrete it through the urine, so the potassium level is going to be raised again. And then lithium and ACE inhibitors together can increase the action of that lithium to lead to lithium toxicity. And that's where these patients develop, or some of the signs and symptoms of lithium toxicity is severe tremors, especially in the hands. These patients get very confused. They have a lot of vision changes, severe nausea and vomiting as well. So we want to watch if they're on lithium, because lithium also contains potassium in it. Any questions? All right. So our nursing interventions, we kind of talked about some of these with them. If we were going to want this medication to lower the blood pressure, we need to check their blood pressure before we give it. We're going to hold it if it's less than 60 millimeters of mercury systolic. We're going to monitor their potassium levels before we give it, and we're going to educate them on decreasing their potassium-rich foods. So, what are some foods that contain potassium?
Banana.
Potato.
Bananas is one.
Potato.
Potatoes. What else?
Spinach.
Avocado.
Cantaloupe.
Avocados. Yep.
Orange.
Cantaloupe.
What?
Kiwi.
Orange.
Kiwi. Yep.
Cantaloupe.
Cantaloupe. Yep. I also have watermelon and beets. So I did not know until I was, starting to teach a lot, that watermelon contains potassium. So I really wouldn't think that it does, but it kind of makes sense because watermelon is made of, to me, I think it's made of water because it's kind of liquid, but it also contains a lot of sugar too. It's one of your more sugar containing fruits. So we really need to be educating patients on these because remember, diabetes goes along with hypertension. So really educating them. And then some of your antihypertensive medications can increase the blood glucose level as well. So we really need to be monitoring blood glucose with it as well. So, are beta blockers? Any questions on the ACE inhibitors? No questions? Okay, we'll keep going then if nobody has any questions. So our beta blockers, those are going to end in the LOL. We have
Professor, sorry, I don't know that I was muted. I was asking a question. I was wondering, how does ACE inhibitor increase blood sugar? Kind of.
How does it? I don't know the pathophysiology of it, but I do know that it does increase blood sugar as well. I mean, I don't know the actual pathophysiology, and NCLEX isn't really going to ask you that, but we just need to know that it can increase the blood glucose levels.
Okay.
You say ACA inhibitors will increase the blood sugar?
They can increase the blood sugar.
Okay.
So we need to be monitoring that blood sugar on these patients, especially if they're diabetic. Your beta blockers can also increase blood glucose levels as well. So your beta blockers end in LOL, and there's 3 different types. They have your cardioselective. So when I think about beta blockers, they work on the heart, and those are your cardioselective ones. So think about it. And think about some of our medications that are alpha and beta adrenergic. That means they help both the heart or they work on both the heart and the lungs. So, like your bronchodilators, albuterol is a beta and alpha and beta adrenergic. So, with those, that's why we see the elevated heart rate in your adrenergic medications. So I look at these, the beta blockers, because beta blockers are contraindicated in asthma. So if they're cardioselective, they're working on the heart, which is alpha, means 1. Beta means 2. If it's blocking 2, it's going to block the heart. So it's it's going to block the lungs and work on the heart. So I kind of think of it, we have 1 heart and 2 lungs. So it's working on the heart rate, being that it's cardioselective, and those are your metoprolol, your atenolol, and your esmolol. And those are very contraindicated in patients who have those are not contraindicated as much in patients who have asthma. So we know that beta blockers are contraindicated with asthma, but if they're cardioselective, these patients, they have been given to patients and they've been okay. Your non-selective, which affect both the alpha and beta, the heart and the lungs, are your propranolol and your nadolol. We also use propranolol and nadolol for patients who have portal hypertension with their liver disorder and their liver disease. And then the alpha and beta are your carvedilol and your labetalol. Labetalol can be given IV, and we do use that IV push, as well as your metoprolol and your propranolol are all available IV. And we do use labetalol quite frequently in patients who come in with hypertensive crisis. We'll give small doses IV push and monitor these patients' blood pressure very frequently. So the actions of these beta blockers, they're going to decrease the myocardial contractility, which is therefore or thereby going to decrease the heart rate. It decreases the rate of conduction, which helps control those arrhythmias as well. So it also has they also have some antiarrhythmic function. decreases the release of that angiotensin 2, which is going to cause vasodilation and increasing the excretion and getting rid of the sodium and the water. We use them for hypertension. We use them for angina. We use them a lot in our heart failure patients because it also increases the contractility, like we said. We use it in a lot of our tachydysrhythmias. Often it's also, especially your propranolol is used in hypothyroidism. And propranolol as well is used as a maintenance medication for people who frequently have migraine headaches. They'll take the propranolol every day. And then for patients who have glaucoma, they also have eye drops that contain beta blockers. So some of your side effects, again, is going to be your hypotension, can increase your blood glucose level, and then it can also cause your bronchospasms in your asthmatic patients. So again, your asthmatic patients, if they needed a beta blocker, would be placed on the cardioselective one so that they're working strictly on the heart. And then it can cause dizziness, obviously orthostatic hypotension, and then impotence. So that poses somewhat of a problem with some of our patients because think about the age group that gets diagnosed with hypertension. It's going to be our males, and they're typically in their 40s and 50s. And thinking about Erickson and Erickson's stages of development, and then Maslow's hierarchy of needs, what does this age group of men in particular want or need? So sometimes these patients wind up with non-inherent issues. So we really need to be doing a lot of education because it can decrease their libido. Contraindications, we talked about pregnancy. They are contraindicated in myasthenia gravis, which is that rare autoimmune neurological disease that causes muscle dysfunction, and then these patients wind up having sensory and muscle issues. We want to use it in caution with patients with peripheral vascular disease as well. Some of our nursing interventions, we monitor the heart rate before we give these medications. A lot of the new studies and the evidence has showed that we can hold it for a heart rate less than 50 beats per minute. It used to be 60. I just happened to be talking to students today about this. If my patient was typically in the 70s and 80s, but I'm going to give this medication and his heart rate is 55, I may be holding it and giving the doctor a call because that's a big change from 70, 80 now to 55. Is there something else going on? Give the doctor a call and use our critical thinking and our clinical judgment. And that's a nursing call. That's an independent nursing call. We've held it for right now, but we're calling the physician. Monitor their blood glucose, monitor for any worsening signs of heart failure, and then administer these medications with food because that will increase the absorption, especially in your PO medications. Keep in mind, tachycardia is typically one of the first signs of an elevated blood glucose. So that's another reason to monitor that blood glucose and that heart rate. And then most often we get a baseline EKG. We cannot crush those extended release tablets because then they're going to get the entire dose all at once. And then we want to monitor the heart rate very closely in patients that are taking calcium channel blockers because the combination of the two medications can lower that heart rate way too low, and then these patients can wind up with severe bradycardia and then, asystole, and we don't want any of that.
Professor, can you go back to the signs and symptoms? Side effects? The
Side effects.
Yes. Okay.
All right. Anybody else? Do beta blockers also lower libido in women? Yes, they can. Timolol, yes, timolol is the medication for glaucoma. Or one of them that they use for glaucoma. So our calcium channel blockers, they're going to disrupt the movement of calcium through those calcium channels in the heart. It's going to slow down how the cells use that calcium, and then therefore it's going to lower the blood pressure and prevent further cardiac arrhythmias. We use them. Some of our calcium channel blockers is one of them is digoxin, which we use for rhythm and rate control. We use these calcium channel, and also cardizem. We use calcium channel blockers for hypertension, angina, cardiomyopathy, pulmonary hypertension. SVT is another one that we use it for, which is that supraventricular tachycardia when their rate is greater than 150. It is an atrial rhythm. These patients may or may not be symptomatic with it. So think about it. If your heart is beaten greater than 150 for a sustained period of time, you're going to start to wear out a little and get low blood pressure. You could be dizzy. You could start to have some chest pain or some palpitations. Typically, SVT is not a lethal rhythm. I have never seen anybody die from SVT. I've seen a lot of it in my career, but I've never seen anybody die from it. But they do become very symptomatic, and we have had to cardiovert some patients to get them back into a slower rhythm just to slow that heart down. We do use adenosine as the first line drug for SVT, but your calcium channel blockers, diltiazem in particular, can be used as well. And those arrhythmias, and then atrial fibrillation as well. So some examples and side effects: nifedipine, verapamil, diltiazem, amlodipine, felidinapine, and these tend to end in your penes. Nicardipine, we also use that one. It is a calcium channel blocker, but nicardipine is one of the medications used for elevate or to lower the blood pressure in ischemic stroke patients. Some of the side effects, so if we're looking at it to lower the heart rate and lower the blood pressure, a side effect could be bradycardia and orthostatic hypotension. It can also cause lightheadedness and dizziness, some of your CNS symptoms, and then peripheral edema and constipation on those patients who are on it long term. Diltiazem, cardizem is known to cause swelling and then some weight gain as well. So think about compliance with that medication. And these patients tend to get more tired in the afternoon. So they may need some education or dosage adjustment. Maybe take it twice a day to keep it, lower the dose, or the physician would lower the dose and administer it twice a day to keep some of the side effects down, especially later in the afternoon. And that has to do with the half-life and the duration of those medications. Contraindication, remember we said every medication is contraindicated in pregnancy. Nifedipine is contraindicated in cardiogenic shock because it acts primarily on those arterioles, and we don't want to further compromise any peripheral blood flow. So, because these patients in cardiogenic shock already have lacked of or decreased peripheral blood flow. So, we want to get that blood flowing. Verapamil can cause, it's contraindicated and can cause severe hypotension, heart block, and digoxin toxicity. And then we definitely want to use cautiously in our older adults and any patients who have kidney and liver disorders. So take your older adults. Remember, we said everything slows down as we age, and that includes the kidney and the liver function. So if these patients are older, already have kidney or liver disease, it's just going to further decrease their metabolism and their excretion of these medications. So some nursing interventions, again, we're going to monitor that heart rate and hold it for a heart rate less than 50 beats per minute. Monitor that blood pressure and hold for a systolic less than 90. Administer IV meds over 2 to 3 minutes and monitor that blood pressure in between. Think about how fast an IV medication enters the system. We don't want to give them a blood pressure medicine and then bottom out or cause hypotension because we've pushed it too quickly. Don't want to crush or chew any sustained release tablets because they'll get the entire dose all at once. And then monitor and educate them on standing to prevent, or going from a sitting to a standing position to prevent that orthostatic hypotension. These medications are contraindicated with grapefruit juice, and we want to monitor their calcium levels because they are calcium channel blockers, right? Any questions on these? Yeah, nifedipine is one of the safer ones during pregnancy. What dose can a patient take for a start and in a day? So it depends on the type of medication. They typically start on the lowest dose if they can, but it also depends on what the trend of that patient's blood pressure is and what the physician puts them on first. Remember, patients who are pregnant, yes, every medication is contraindicated in pregnancy, but pregnant women do need medications, especially think about our pregnant women who develop heart failure. They're going to need some of these medications. That pregnancy-induced heart failure. Our diabetics, insulin is safe during pregnancy when these women develop that gestational diabetes. So it doesn't mean we don't administer them. It just means we use them in caution, and that's a physician's, obstetrician's decision and the medical doctor. So our diuretics, they're going to affect the urinary output and they're going to regulate blood pressure. So there are 4 types of diuretics: your loop diuretics, your potassium sparing diuretics, your thiazide diuretics, and your osmotic diuretics. So the loop diuretics are kind of the big guns. We give those a lot for patients who come in with ascites because of liver disorders. For heart failure, we administer that frequently IV. Your potassium sparing diuretics are given a lot to patients kind of like as a maintenance if they have heart failure. I don't know if maintenance is kind of the right word, but they may go home on a loop diuretic, the Lasix furosemide, and then they may switch them over to a potassium sparing, which works, but it doesn't work as well as those loop diuretics. But there's more complications with the loop diuretics related to the potassium being excreted as well. Your thiazide diuretics are going to be get rid of more water and kind of spare. It does release and excrete potassium. Those are going to be your hydrochlorothiazides. Your thiazides. You have that in the word. And then the osmotic diuretics are used to decrease intracranial pressure, and that's going to be your mannitol. So our loop diuretics are going to work primarily in the loop of Henle in the kidneys. So they affect the excretion of urine, right? And they block the reabsorption of sodium and chloride. They prevent the reabsorption of water, and they cause excessive diuresis. So if have any of you ever given Lasix IV before?
Yes.
Yes. What happens when you gave IV Lasix? How much did they diurese? A lot. They should have.
Yeah, a lot more than what they used to diaries.
Right. So we can give 20, 40, 80. I've given up to 100 milligrams of IV Lasix. Sometimes if patients are really, really sick and have a lot of fluid we need to give off, they'll put them on a Lasix drip IV. Uses of these diuretics: hypertension, heart failure, pulmonary edema, kidney disease, and like I said, your hepatic disorders, the ascites in that hepatic disorders. We can give a lot of these diuretics oral, IV, or IM. Your side effects are going to be hypotension, dehydration, dry mouth, hyponatremia. They do, especially your loop diuretics, are going to cause ototoxicity. So these patients start having either ringing in the ears, or they're having some start of some hearing loss. Hypokalemia, and also hyperkalemia. I'm sorry, hypokalemia, not hyperkalemia. Hyperglycemia. And then it can increase their LDL cholesterol levels as well. Did somebody have a question or a comment? I've given 60 and 16 mLs of normal saline. Yeah. So it is contraindicated in pregnancy, but again, we have had to give pregnant women who are in heart failure because of the pregnancy furosemide. They can increase the serum lithium levels as well. So, and also, if the patient is taking digoxin, it can increase the digoxin level to cause toxicity as well. We want to use in caution if these patients have cardiovascular disease. And then if they have no urine, we don't want to give them a medication, or if they're not able to urinate, we don't want to give them a loop diuretic. It can interact with digoxin by causing some ventricular arrhythmias, which are the bad ones, so we don't want it. Concurrent use with other antihypertensives can further lower the blood pressure because these medications cause hypotension. So it doesn't mean we don't give them. It just means we have to monitor them more closely. And that's a physician and patient call. NSAIDs are going to decrease the blood flow to the kidneys. And remember, NSAIDs can also cause kidney damage. So we don't want to administer both of them. If they're decreasing kidney blood flow to the kidneys, that's doubly causing kidney damage. Nursing interventions, we definitely want to get a baseline vital signs and also monitor their blood pressure and potassium before we administer them. Definitely going to monitor their I's and O's, and then tell these patients to go ahead and eat potassium rich foods because they're getting rid of the potassium. IV push is typical, or if it's administered IV, we're pushing it at 1 ml per minute. So if we're giving 4 mLs, we're going to be in that room for 4 minutes administering that IV furosemide. Daily weights, and then increase those foods rich in potassium. Any questions on the loop diuretics? So when we say, the question is, when we say contraindicated, does it mean they can't take it? So for the most part, yes, it means it shouldn't be given, but it doesn't necessarily mean, it depends on what it is and what the interaction or the contraindication is. So again, it's contraindicated in pregnancy, but that doesn't mean that a patient who's pregnant isn't going to need it if they're in heart failure or caused by the pregnancy. So for us as nurses, that's not our call. That's a physician call. But if this person's pregnant and they order furosemide, it's my job as the nurse to know it's contraindicated or it's used in caution, and I would give the physician a call and hold it. Make sure he knows that the patient's pregnant. Or make sure that I have talked to him and knowing that the patient is pregnant. And that's a nursing intervention. Does that answer your question? Yes. Okay. So,
I have a question, Prof.
Sure.
But it's on channel blockers. I just want to ask, the avoidance of grapefruit, is it only when the medication is given, or the hypertensive patient is supposed to avoid it entirely?
So it depends on the medication. Some you can give it to you can eat grapefruit or give the medication 2 to 4 hours apart. It just depends on the medication. So remember, we're kind of doing an overview. If you had an NCLEX question related to that, I would say you're not going to give it because it's going to interact. You're going to hold the medication and call the physician.
Okay, but I'm asking in respect to grapefruit juice.
I know, and I'm kind of answering that. It depends on the particular medication. Most of your antihypertensives interact with grapefruit juice. So if I had an NCLEX style question and it gave me the patient wants grapefruit juice and is on an or gives you a medication, it'll give you a medication, and then it'll say the patient wants grapefruit juice for breakfast. What is the nurse going to do, or something like that. I would suggest you answer it, to hold the medication and call the physician. So remember, NCLEX tests nationwide, and NCLEX tests on everybody and the majority. The most people. So I would say I would hold the medication and call the physician.
Okay, thank you, Prof.
So your thiazide diuretics are going to work in the distal convoluted tubules. They block the reabsorption of sodium and chloride, and they prevent the reabsorption of water. It's going to promote diuresis in those patients with impaired renal function, and they're going to spare that potassium. So we would want to monitor the potassium level on this patient. They're often the first choice for hypertension. Again, they work, but they're not as, I call the loop diuretics the big guns. So if you were going to administer a thiazide diuretic to a patient and their potassium is 4.8, what would you do?
You hold the medication, right?
Yeah, withhold the medication. Even if it's high normal, even if it's still within the normal range but higher, some of our US labs go up as high as 5 on their potassium. That the normal is 3.5 to 5. Some are 3.5 to 4.5. But if it's 4.8 and it goes to 5, I would definitely be holding it and still calling the doctor, because if it's going to retain that potassium, it's going to raise that potassium level, right? So we want the doctor to be aware of what the level is right now. He may tell you go ahead and give it, but that's his call, right? We use them for hypertension, edema. A lot of times they're used in combination with hypertensive meds, and we do use them with diabetes insipidus, and to help promote the reabsorption of calcium sometimes as well. They also are used in conjunction with that calcium to reduce the risk of postmenopausal osteoporosis. Examples are your chlorothiazide, the methachlorothiazide, adaptamide, that's one of your stronger ones, and metolazone as well. They're contraindicated in pregnancy because they decrease the maternal blood flow to the fetus and the placenta, which is what feeds the fetus and supplies the blood flow to the fetus. Breastfeeding, they're contraindicated because it can cause harm to the infant. And then lithium use, because it can increase the lithium level to toxic, or they can increase the lithium level to toxic levels. So some of your side effects are going to be the same as your loop diuretics, dehydration, except this can cause, it should be hyperkalemia. I'm sorry. That should be hyperkalemia. I'm going to highlight that so that I fix it. Hypochloremia, hyperglycemia, hyperuricemia, which is going to increase that uric acid. So your patients who have gouty arthritis. And then hypomagnesemia, which could also lead to some cardiac dysfunctions as well. Can also increase the lipid levels. So you see there's a theme here with a lot of these medications. Even though they're thiazide and loop diuretics, both of them can increase the lipid levels. They both affect potassium, obviously in two different ways. One causes hyper and one causes hypo. And a lot of their interactions are going to be the same as those loop diuretics. These medications do not cause a risk for hearing loss or ototoxicity. So that's a lot of times why they're the first line medications too. Some of our nursing interventions, if we're given it, we're still monitoring the blood pressure. We're monitoring that potassium level to make sure it's not too high. We might give them some ice chips and liquids to combat that dry mouth. We're still going to weigh them daily. And strict I's and O's on these patients as well. And then monitor their cholesterol levels. So with both types of diuretics, you see our nursing interventions are basically the same. We've talked about the same things with both of them. So if I was a student studying, I would make myself a comparison chart of what do they do. They both nursing interventions, we got to monitor the blood pressure, monitor the potassium level. I would put hyper on one and hypo on the other, hypo on the loop and hyper on the thiazide. We're going to give ice chips. We're going to monitor daily weights. We're going to do strict I's and O's, and we're going to monitor that cholesterol level, right? And your potassium sparing diuretics, those are going to then spare your potassium. They block the action of the aldosterone. So remember, aldosterone is going to retain sodium and water. So these medications block that reabsorption, which results in the potassium retention and the excretion of that sodium and water as well. So your potassium sparing diuretics work very similarly to your thiazide diuretics as well. We use them for hypertension, edema, heart failure, and then your hepatic disorders as well. A lot of your same side effects. These do cause more gynecomastia, hirsutism, which is increased hair growth, and more CNS than some of your other diuretics. They can also cause metabolic acidosis. Think about all the electrolytes we're excreting and then what we're retaining as well. And then they can cause impotence as well. Nursing interventions are going to be the same. With these, we're going to monitor more CNS side effects. You might want to get your baseline EKG for any of them, or look at the baseline EKG that might already be on the chart. And then educate these patients with any of them to avoid adding salt to their foods, because again, that sodium is going to increase that blood pressure. And what's the purpose of giving these medications is a lot of times to decrease the blood pressure. Any questions on any of those so far? Would you please give recorded video to study later? Yes, it does get posted. All videos or all sessions are posted after. And you should have a copy of the slides because I already posted those. Our osmotic diuretics are going to reduce intracranial pressure and intraocular pressure. So we use these in a lot of our traumatic head injuries or brain injuries. And then too, if somebody has tumors, because remember, anything that's going to increase their intracranial pressure. Sometimes patients who are ventilated develop increased intracranial pressure from being on the ventilator. So they may be on some of your osmotic diuretics as well. They're going to raise that serum osmolality and draw fluid back into the vasculature and the extravascular spaces. We use them to prevent kidney failure and hypovolemic shock, to decrease ICP, to decrease intraocular pressure, And then they are administered in that oliguric phase of acute renal injury because it's going to help get the kidneys to work. The example and the only one I know and I've ever used is mannitol. Side effects, they can cause some dyspnea, fatigue, changes in LOC, so some CNS side effects, headache, nausea, and vomiting, and some of your GI side effects as well. Again, we're going to monitor that blood pressure very, very closely. Monitor the ICP, and these patients are more often than not in the ICU when they're getting that mannitol, so they can be monitored for increased intracranial pressure. And then we're going to monitor their lithium levels because those lithium levels can be increased and interact with the diuretics to increase the toxicity levels. So that is all I have on those. I do have a bunch of questions that we're going to talk about stuff too. So no matter how many mistakes you make or how slow you progress, you are still way ahead of everyone who isn't trying.
Absolutely, Professor.
Yep. I try to end on a good note, right? It's a lot of information. Does anybody have any questions?
For someone who has a family history of hypertension but isn't yet diagnosed with hypertension, which salt is advised for the person to be using, sea salt or iodized salt?
Neither. You should be using salt substitute, or not even salt substitute, but use like your powders, garlic powder, onion powder. Mrs. Dash doesn't contain any salt and has a lot of seasonings. Fresh herbs and basil, that kind of stuff. Yeah, no salt somebody put in there. Yeah, they should not be using salt, especially if you have a family history and other risk factors. Think about those patients or those people that are at high risk. What are some of the factors or the people who are at risk for hypertension? Our obese patients, our patients who have diabetes, our African American population, unfortunately, patients with cardiovascular disease, smoking, all of those can all increase their risk for hypertension. Any other questions? Break time? Okay, you can take a break if you want. I'm going to keep going because I'm here for 2 hours. So let's practice. A nurse is caring for a client on furosemide for heart failure. Which of the following interventions should the nurse prioritize before administration? So remember, with your priority questions, they're all going to be correct. You're going to do pretty much all of these things, but what are you going to do first?
Assess the blood pressure.
Assess the blood pressure. Absolutely. So we're going to get that blood pressure because remember, it can decrease that blood pressure. It can also decrease that serum sodium and calcium level, right? We get the blood pressure, we're going to get a full set of vital signs. So we're probably going to get a temperature, but is that going to weigh into or factor into us giving that medication? No, not at all, right? Everybody see that? Good job. Everybody got all I see all C's. A nurse is caring for a client with a ventricular tachycardia. Which medication would the nurse anticipate to be prescribed?
A.
Amiodarone, yeah.
Yep, amiodarone, absolutely. So, good job. You guys are on it tonight. Yeah, so it would be amiodarone. That is an antiarrhythmic, and it's specifically used for ventricular tachycardia. There's 2 different doses. It's going to be 150 milligrams IV push if they're in ventricular tachycardia and stable or have a pulse. If they don't have a pulse and they're in cardiac arrest, they can have ventricular tachycardia without a pulse. And then we would give 300 milligrams. We're not going to give somebody who has a tachyarrhythmia epinephrine, because what does epinephrine do? Increases the heart rate. Procainamide works more on the blood pressure, and atropine is going to increase the heart rate as well. We give atropine for bradycardia, and that's the treatment for bradycardia. So, good job. A nurse is assessing a client for signs of digoxin toxicity. Which symptom is indicative of digoxin toxicity?
C, yellow-green light halos and palpitation.
Yep. Wow, you guys are on it tonight. Yeah. So one of the major side effects of digoxin is it can cause ventricular tachycardia, and it causes that polymorphic ventricular tachycardia. And that is a sign of digoxin toxicity. These patients complain of seeing halos around the lights. If you've ever looked at the sun, directly at the sun on a really bright day, and then look away and you get all those weird halos, that's kind of like how they describe it. Headache and weight gain is not a sign of it. Some of the other signs of digoxin toxicity are severe nausea, vomiting, and then they obviously will come in and having palpitations sometimes, but they don't know they're in ventricular tachycardia. So, good job. A client is experiencing paroxysmal supraventricular tachycardia, PSVT. Which medication should the nurse prioritize administering to restore normal heart rhythm?
B, adenosine.
Adenosine.
Yep. B, adenosine. So adenosine is only for SVT. That's the only thing that adenosine was made for. What do we want to monitor when we give adenosine, or has anybody ever given adenosine? Yes. What did you do, or what were some of your nursing interventions? What did you do before you administered it?
You tell them that the patient and the family that they are going to see a straight line in the cardiac monitoring, that they should not be panic.
Right.
And you do it rapidly push.
Is it the apical pulse?
Well, you do need to monitor the heart rate, absolutely. So, and you do want, I would not tell them you see that. I would tell them, and then we don't freak out as nurses, right? Ready with emergency tray. Yep, that's what I was looking for. What's your emergency tray? Your cardiac defibrillator. Because if these patients don't come back, or if it causes that, because it's a chemical cardioverter. It makes that heart stop and refunction, I guess, is for lack of a better word.
Reset.
So, reset. Yes, reset. So that's what I was looking for. So we want to make sure that we have everything we need. We want to put them on oxygen beforehand. And patients complain of feeling like they're like, oh my God, I feel like everything just got drained out of me. Well, it just did pretty much, right? So that is the only IV medication that we push quickly. Does anybody know the half-life of adenosine? Do you know what the half-life means? The half-life is, yep, 7 seconds. It's less than 10 seconds. So that's why we push it quickly, because it's less than 10 seconds. And on the opposite end of that, does anybody know the half-life of amiodarone? Amiodarone's half-life is 30 days. So that means that medication can be in the patient for 30 days. Adenosine, it goes very quickly. So that's why we push it quickly. And it's always followed by a saline push as well of at least 10 cc's. You definitely want to, I mean, I've given it so many times in the ER. What you want to tell the patient is you're going to have a weird feeling. It only lasts 5 seconds and we're right here with you. So reassure them, let them know that they may feel weird and that you're right there to do everything you need to do. I don't necessarily like explain to them that your heart's going to stop. I tell them it's going to bring your heart back to a regular rhythm or reset your heart. In order to do that, we have to put you on the cardiac monitor. You're going to see the doctor in the room, the nurse in the room. So, explain to the patients what's going on. That's part of what we do as nurses. Somebody put in their sleep regulation. I'm not real sure what you mean by sleep regulation for adenosine. Are you thinking of a different medication? Okay, maybe not. Yes, the heart does stop and it resets itself. A client on digoxin has a serum level of 1.8 nanograms per milliliter. What should the nurse do first?
A, stop the digoxin, inform the healthcare provider.
Okay. Why do you say that?
Because 1.8 is over the therapeutic level for digoxin.
For
No,
digoxin toxicity, yeah.
it's not over.
I will administer it after the doctor prescribe.
Monitor for sign of the therapeutic drug level is 0.5 to 2.
Is it
Right.
So 1.8 is
Two, okay.
normal, so you
Oh.
would administer.
Yeah.
I was thinking of lithium. Look at me, yeah.
Administer it.
We should
Yeah.
monitor the cleanse for sign of.
So the correct answer is you're going to administer it.
Yeah.
Because the normal digoxin level is 0.5 to 2.
So if we're going to administer, Professor, won't it go overboard? Because I would have said probably we want to monitor a little bit and see. But you said we should administer it. All right.
Well, the correct answer is you're going to administer it. So what this question is asking is it wants to know that you know what this normal digoxin level is. The therapeutic level is 0.5 to 2. Anything above 2 could cause toxicity. But if they're not having any signs and symptoms, this is still within normal limits. Giving the digoxin is not going to make it go up that quickly to cause toxicity right now. That happens with this particular medication. That happens over a little bit of time. So if I'm giving it, the doctor may order another digoxin level in a week. The half-life on digoxin is longer as well. So that toxicity happens a little slower. Lasix works very quickly. So if you ever are kind of in doubt, look at the half-life and look at the duration of how long these medications stay in the system, because that's how they're dosed. They use half-life and duration for dosage recommendation. Does that make sense? So the correct answer is B, you're going to administer it because it is within normal limits. I just want to make sure. Don't be in a rush to answer, please. Okay. A nurse is reviewing adverse effects of captopril with a client. So think about what is the classification of captopril. Which of the following should the nurse include? So these are all, select all that apply. So you're going to have more than one answer choice.
A and D. Right there.
I think ADE.
Okay, so adverse effects.
A and D.
A and what?
A and D
Yeah,
as in dog.
D as in dog.
Dog. A and D.
Okay, so these are adverse effects. So we don't want these, or
We don't want the side effects, right?
Right.
Okay.
They're going to be, the adverse effects are going to cause harm to the patient. A side effect, an adverse effect can cause harm. A side effect is something we know that can happen and doesn't necessarily cause harm to the patient. So, like with your prills, remember we said we know it causes a dry cough and we know it causes angioedema. So, adverse effects are those things. And we also know that it causes a side effect is orthostatic hypotension. But of those, what's going to cause the most harm to the patient? It's going to be your orthostatic hypotension, your hyponatremia, and your bradycardia. Dry cough hasn't ever killed anybody that I know of. So when I think of adverse effects, think about, because remember, NCLEX wants to know that you can safely take care of a patient and not harm a patient. So if a patient has orthostatic hypotension, what could happen?
They can fall.
They can fall, they can pass out, they can hit their head when they fall, right? So what could happen with hyponatremia?
Change in LOC.
Change in LOC. They can have all kinds of CNS effects. They can also have metabolic acidosis and alkalosis, depending on what else is going on, right? And then what about bradycardia? What are some bad things that can happen to patients if they become too bradycardic? Same thing as orthostatic hypertension. They can fall, they can pass out. Anytime a patient comes in with a syncopal episode, we check their heart rate, we check their blood pressure, we do an EKG because they could have been bradycardic, right? Does that make sense to everybody? Low perfusion, yeah. Hyponatremia can cause seizures, exactly, and confusion. Somebody mute your microphone, please. Sounds like somebody's driving.
I guess it's John.
Trying to see if I can mute it. Okay, there we go. So answers, please. Answers to this is A, C, and E. A nurse is reviewing new prescriptions for propranolol. For which of the following clients should the nurse question the prescription?
Asthma, right?
Yeah, a client with asthma. So remember, the answer is D. So remember, we give beta blockers post MI, cardiac myocardial infarction. We give beta blockers for hypertension, and we give beta blockers for rate control and rhythm control as well. So we may give it for atrial fibrillation, right? But they are contraindicated for the most part with asthma. A nurse is caring for a hypertensive client on amlodipine. Which of the following statements by the client indicate a need for further teaching? So with this one, you're looking for incorrect answers, right? Because this patient's saying something that's incorrect and you need to give him more teaching. So it's select all that apply.
B and E.
Right. So how I tell students is kind of reword this. Because we're looking for an incorrect answer, right? So go down each one of them and ask yourself, does amlodipine cause the heart rate to be between 60 and 70 beats per minute? Yeah, that's good. Or do we want the heartbeat to be within 60 or 70 beats per minute on amlodipine? So that's a correct answer. I will experience less dizziness when I take the medication. Well, that would be incorrect with any medication, right? I take the medication at the same time every day. Yeah, because half-life, remember, and the times that we take the medications. I will contact my doctor if I experience any chest pain. Well, that's not incorrect because anytime somebody has chest pain, we're telling them to call the doctor or call EMS and go to the hospital, right? And then I rarely measure my blood pressure when I am feeling better. No, you need to monitor it all the time. So your correct answers are B and E for this question. A nurse is educating a client who is on verapamil for atrial fibrillation. Which of the following statements by the client indicates a need for further teaching?
D.
Right. Why?
Like you stated earlier, side effects are normal things that we experience when we're taking medication.
Yeah.
So even
We
when they're
know
taking,
about, yeah.
yeah.
We know that those are going to be side effects. So rather than, but this is a very common thing. A lot of times, whoops. A lot of times patients start to experience these side effects, so they stop taking medications. So we, educating them on what the major side effects are or the ones that can be troublesome. Anytime we give antibiotics, we tell them you may want to take this with some food, right? Giving them this medication, we may tell them things to watch for and things that could occur that are normal. If we give pyridium for a urinary tract infection, we always tell patients it's normal. It's going to turn your urine an orange or dark brown color, right? So those things that are common and that we know, we want to educate them on.
Can I ask something about the C? Can you put back? Yeah, can you put back the question up there? Let me say something. You see, like I don't know if this is a tricky question here. That said, I will avoid grapefruit juice while taking this medication. That is true too, right? Or no?
Yeah. Oh, it is.
Because some medication you don't take. Most medication they don't want you to take a grapefruit juice.
I would have to look at verapamil C. Hold on.
But Professor,
but the answer says I will avoid, not I will take.
Yeah, so
the statement is right. You're gonna avoid grapefruit. That is a true statement.
Oh yes, yes, it is.
Yeah, it's right.
Yes, thank you.
We are looking for first
It's late at night, y'all. It's it's late here. Yes, we will. They will avoid it, and that's a true statement. We're looking for an incorrect statement. Yes, you are correct. Thank you. So, does that make sense? Whoever asked that question about B?
Yes, I did. I overread it. That's why.
Right. Yeah. See, and I did the same thing, that mistake. So that's a good test taking strategy. I wasn't completely focused, and you guys sometimes aren't completely focused when you're doing NCLEX. So if you start to feel, like you're kind of losing it or you're tired, get up, take a break. You can't take an hour break, but walk to the bathroom, splash some water on your face, stretch, do something that's going to help you to refocus and reset you. Asking for okay. Can cause rebounds, arrhythmias if stopped abruptly. Never stop a medication without the PCP approval. Exactly. Does anybody else have any other questions? I'm here to answer you guys. You have time to ask questions.
That was the last question?
Yes.
Oh, okay. So yes, I have a question.
Sure.
So hold on, because I wrote it down. Adverse effects cause harm, and side effects are, what would you say before?
So side effects, how do we know what these side effects are, right? Side effects are when they do any drug that goes through the US, and I'm sure it's the same in other countries, has to be regulated. So they do drug trials and they ask patients or people or they do it on rats or some other stuff, and they look at what are the side effects that occur in those patients. So if one patient experiences something that's not expected, that's considered a side effect. So we know about those. Those aren't really considered harmful. But if they cause hypotension, those are going to be adverse effects, because what do we want these medications to do? We want them to lower the blood pressure or lower the heart rate, but we don't want them to cause hypotension or bradycardia. So I tell students, think about those adverse effects as those that could cause harm to the patient. Does that help?
Yes. Do you mind going back to that select or apply question? The
Which
one
one?
that
We
says
had a
adverse
couple.
effects.
This one?
The one it was a select or apply.
Okay, this one?
Yes.
Okay.
I just want to see it. What was the answer for that one? A,
C, and E.
A, C, and E. Okay.
So if you're not sure on those, ask yourself, kind of like what I did when we went through it, what could happen to the patient if they develop orthostatic hypotension? And you all said they could fall, they could pass out, they could have a low heart rate, they could harm themselves, right? And that would not be good. So I would call that adverse effect. Hypokalemia is that medication. So for this particular question, you would have to know a little bit about that medication. It does not cause hypokalemia. It can increase potassium. And then hyponatremia, this patient could be confused, could have some metabolic disturbances, could have seizures if they're severely hyponatremic. A dry cough has never killed anybody. And then bradycardia can occur and they can cause harm. They may need a pacemaker. Their heart may stop completely. So those can cause harm to the patient.
Okay. Thank you.
You're welcome. Any other questions?
Professor, I never know that it could cause hyponatremia. I'm just trying to figure out why it causes hyponatremia.
The captopril? Let's go back to our prils. Close your eyes if you get dizzy. Sorry. So remember, it's going to reduce the amount of angiotensin. It's going to excrete sodium and water. So when we excrete sodium, we could become hyponatremic. So what's worse? The prils are going to retain that potassium in the kidneys. So even though hypokalemia can be, because that was an answer choice, can be harmful for a patient, the prils don't cause hypokalemia, right? They can cause hyperkalemia. But excretion of sodium and water, it does that. And we don't want that adverse effect. We don't want it to go too far and excrete too much, right? that it can lead to hyponatremia and can lead to seizures and metabolic disturbances. Does that help?
Yes. And the bradycardia is the relationship of orthostatic blood pressure.
Well, bradycardia it can cause a low heart rate because remember, your prills also work on blood pressure and heart rate. But we want it to lower the blood pressure to a normal rate. We don't want it to cause bradycardia.
Yeah.
About EKG need add class. But I don't understand what you're asking. You're wanting an EKG class?
Yes. One class for EKG.
Okay. You might want to talk to, so the content that I teach, we all get from Naxlex. So you might want to suggest that. I do talk about different rhythms with some of the lectures if they're related to the medications and stuff. Any other questions? You're welcome.
Thank you so much, Officer.
You're welcome. I'm responding to the
Professor?
Yes.
Can you please go back to beta blocker?
Yes. Okay.
I want to see the what is the uses like the hypertension and stuff like that.
Okay, sure. Is that good?
Just give me one more second.
Sure. I just didn't know if you wanted something else with beta blockers.
No, I was taking down notes and I forgot what to take down the notes on that one. Okay, good. Thank you.
Okay. Anything else you need on that?
No, I got everything now.
Good. Okay. Nobody else has any questions? Can you see the diuretics slide? Yes. Which diuretics? I can't, you're going to have to talk to me and tell me which ones. This one here or?
All of them.
Okay. Anything, do you have a question in particular or?
No, I just want to see the slides like the thiazides, the loop diuretics, the notes under them. Thank you.
So let me know when you want me to change them.
Sure. Next slide, please.
Do you all use what drug book do you use to look up medications?
Next slide, please. Next slide, please.
These slides are posted.
Thank you. I got this one, just making sure I got all of them. Sorry.
No,
All
I
right.
mean, I'm just letting you know that they are posted.
Okay. Yeah. Yeah, I got this. Thank you.
Okay.
Professor, for the the diuretic, should patient avoid that avoid sulfur for that?
Sulfur?
Yes.
I don't know about that. I would have to look at that. What?
Like if they have sulfur allergies to it or so,
Oh,
you should avoid it.
Okay.
Yeah.
Let me look at my drug guide. I've never heard that before.
I think it causes like for the sensitivity. If they are allergic to sulfur, they shouldn't take it.
Oh, look, you taught me something. Yeah, there's a cross sensitivity. Well, it's sulfonamides, and loop or thiazide diuretics. If they've had so your sulfonamides are your antibiotics.
Yeah.
Yeah, there's a couple studies on it. I'll have to go look at that. I did not know that.
The capabilities of this ship and the strength of its armaments are limited. I ask for your greatest effort.
Hydrochlorothiazide is safe. Your potassium sparing are safe. Oh, I didn't know that. Look, you taught me something too.
Thank you.
Thank you. I've never heard that. Wow. All right. Well, if nobody has any questions, somebody was asking about the slides. They are posted with the previous webinars.
Good night, Professor. Thank you.
Good night. Y'all have a good night.
Good night.
Good night.
Good night.
Thank you. Good night.
You're welcome. Good night.
Thank you.